Today my talk is entitled Max Models and Immunity, and it's going to be a very broad, high-level, cross-cutting talk looking at practical approaches to deal with heterogeneity in infectious disease risk. This is work that has been done with a large team of people, or many large teams of people, and more than I can list here, and everything that is good about the talk can be attributed to them, and everything that's bad about the talk should be attributed to me. So if you know anything, and I'm not saying you do, but if you know any result from infectious disease dynamics, this is probably it. And it's the critical vaccination threshold, so the amount of vaccination we need to keep a population safe for invasions of diseases, is equal to 1 minus 1 over the basic reproductive number. And this basic reproductive number, to remind you, is the number of infections that we expect a new infected person who enters a fully susceptible population to cause in that population. So if this guy in red here has entered a fully susceptible population and the basic reproductive number is 4, we expect him to cause 4 secondary infections. But this number and we can do a lot with this number, so this number and the results that come from it come from an assumption that the world behaves like a gas in a box, that we all walk around randomly bumping into each other, infecting each other, and there's no population structure at all. But in fact, we know real people live in households and have workplaces. These households and workplaces exist within cities and have their own complex structures and mechanisms of interaction. And these cities, in turn, exist within nations in a worldwide transportation network that also has highly structured interactions. And this can matter. And I'm going to give 2 quick examples about why it can matter. So it's been a little bit now, but I presume you all remember a couple years ago, Ebola raging through West Africa. And the CDC came out with a projection of what the epidemic would look like that was uncontrolled, if it were uncontrolled, that suggested that by January 2015, if the epidemic was uncontrolled, and this is coming out in September, we could see as many as 550,000 cases of Ebola just in Liberia and Sierra Leone. Now, I had a good friend who was on the ground there with the WHO at the time, working as an epidemiologist, and when they saw this, their conversation changed. Like, this projection mattered, because suddenly the conversation changes between how do we control and mitigate this epidemic to, do we need to get our people out of here to keep safe? Do we have an exit strategy? So that's a distraction. What really happened is that there were, by around January 20th, there were about 19,000 cases in these 2 countries. So there was a far, far smaller epidemic than was projected. Now, this number gets beat up a lot. To be fair, it was a number based on an uncontrolled epidemic, and we didn't actually sit there and just let Ebola rage through West Africa uncontrolled. But at the same time, I think most people in the know still thought it was way, way too big and way too pessimistic. And part of the reason is while they captured some sort of the heterogeneity in transmission, is they treated each country as if it was a giant homogenous bag of people. And this is some work we did that was never published, but if you broke down and looked at the county level at that same time, the epidemics that were happening at the county level, all of them were receding very quickly within a month or 2 after the introduction. And the reason, so even though the overall number was still having exponential growth as the epidemic entered new areas, in none of those areas was it sustaining for a long period of time, or as long as you would think if this sort of uncontrolled general population epidemic happened. So heterogeneity likely mattered in that prediction. Here's another example. So these are contact distributions from a study we do in China. So how to read these figures is On the left is a probability, a proportion of the population on the y-axis, and then on the x-axis is a certain property about how people make their daily contacts. So let's focus in on this one on the left. So this is the number of contacts that people have during a day, that people report during a day. And most people are reporting somewhere around 10 contacts, but some people, a very small proportion of the population, produce a very, very high number. We have people reporting as many as 1,000 contacts. Anybody want to guess what somebody who reports 1,000 face-to-face contacts does for a living? Toll booth, right, exactly, toll booth operator. Yeah, because we saw this data and we're like, that can't be right. And then we saw it was a toll booth operator, and yes, it was right. So, all right, we notice this heterogeneity there, but this heterogeneity could have different structures. And I'm going to give you two extremes of how it might work. On one extreme, everybody might wake up in the morning and randomly select, weighted by this distribution, a number of contacts for the day. That's not how the process would work, but that could be effectively what was happening. None of the amount of contacts that we were having for a day would have anything to do with who we were, but would have everything to do with just this random distribution. So that's like a completely random selection of contacts. On the other extreme, we could all be living Groundhog Day. I don't know if people are probably too young to anymore, but we could all be reliving Groundhog Day. And so doing the exact same thing every single day. So if I'm a 12 contact person, I'm a 12 contact person. If you're the 13th person I'm going to meet that day, I don't want to see you. I just have 12 contacts every day. So both of those are two sort of extremes, and we know the truth lies somewhere in between of how this distribution could occur. And depending on what extreme we are, we get very different epidemic dynamics. So if you run a simulation in that Groundhog Day scenario, where they're not necessarily the same contacts, but everybody's having the same number of contacts every day, you get this very fast, intense epidemic shown in the yellow here. Whereas if you have this random selection of contacts every day, you get a more gradual epidemic, like the one shown in the red here, that looks a lot like what we see if we assume sort of homogenous mixing, just random gas in a bag type of interaction. But this yellow epidemic ultimately will infect far fewer people. This is the number infected in a population of around 50,000. Ultimately will infect fewer people, even though it's more intense than this sort of random picking everyday epidemic. So you can imagine that if you're actually closer to this case and are making an epidemic projection, thinking you're in this case, you're going to way overestimate what's going to happen. So I'm just using those examples to sort of set the stage for thinking about how do we deal with this in a practical manner. Now, one technique or approach that some people take is they model everything. So they say, okay, we're going to make an agent-based model, and we're going to try to represent every single person in the United States or every single person in the world and how they interact and how they move disease around the world and everything about it. And at some sort of deep philosophical level, you could argue that's like the ultimately right way to do things. It could capture anything. There's no scenario you can come up with that cannot be captured by such a model. But when we start thinking in practical terms, it's not really such a great approach. For one thing, we have to go out and collect all that information, and we may be doing so in a crisis situation, in an Ebola or Zika type of situation. So we have to collect all that relevant information about how people interact, where people are, what they're doing. These are very computationally intense, so you have to run them enough to be able to make valid forecasts and valid statistical inferences. So as a practical matter, at least where we stand now, these models are useful for some things, but they're not useful for for a lot of practical public health questions. So the question that all the methods I'm going to present in this talk is structured about is how do we make effective and timely decisions in the face of complex social networks and situational uncertainty. And the paired question to that, in order to do that, is how do we measure the structure of disease transmission and the landscape in which it occurs. So we're going to go through a few vignettes here that highlight work that me and my group have been doing over the past decade or so, a little less, trying to get at these questions. And the first question we're going to look at is sort of the most basic. Where are the cases? If you're going to respond to a disease, you kind of want to know where it is. And we'll frame this within a disease where there's very specific practical questions that involve where the cases are, and that's cholera. So the current situation with cholera is we have a good vaccine. We have a good world cholera vaccine, but we don't have a lot of it. So in 2015, there were about 2 million doses available worldwide. Last year, there were about 10 million doses available worldwide. There were 1.5 billion people at risk for cholera by some estimates. So the amount of vaccine we have is completely inadequate to the task of protecting everybody we want to, at least by traditional means. So what are the best strategies for deploying the stocks we do have? How do we get those to the people that need them? And also, would it be cost effective to increase the supplies? One of the reasons the supplies are so low is if you think of cholera vaccine like you would think of deploying a normal vaccine at sort of a country level, countrywide program, it's not very cost effective. And you'll kind of see why as we go into this a little bit. So this is a map of cholera risk in Africa with these dark greenish-brown areas being the countries at highest risk. And one of the countries with the highest rate of cholera is the Democratic Republic of Congo. Now, I think it's 45 million people live in the DRC. So it's a pretty big country, and covering everybody there, as I just shown, would be far beyond the vaccine supplies we have available today. But if we look at DRC, if we zoom in up on DRC, we see that the scenario is a little bit more complex. So this figure on the left here, we have a measure of annual incidence on the square rooted here, mean annual incidence here on the left. And the x-axis is showing the amount of year-to-year variation. So places on the left side of the figure are having the same thing happen every year, and places on the right side of the figure have a lot of year-to-year variation in the amount of cholera they see. And you can see that these 10 places up here, 10 districts up there where all the cholera is occurring on a regular basis. Those are really the source of the cholera problem in the Democratic Republic of Congo. And they're all along for the most part, along this lakes region in the eastern part of the country. So potentially we could focus on those areas. So we wanted to do this on a more global scale. And we've been focusing on Africa now. And what we've been doing is we've been going along and sucking up basically all the data on cholera incidence we can get our hands on. We've been doing this for a few years. And this map shows the data we have. The darker red areas are areas where we have data on the sub-district or even point pattern data. So very, very high resolution data on the occurrence of cholera. And the sort of lightest level areas are places where we only have, they show up as white actually on this projector, but those are places where we have just country level data. And so we've used statistical mapping techniques and covariate models to convert this into a map of cholera incidence rates. And so this map shows for Africa the incidence rate, mean incidence rate of cholera for every 20 kilometer by 20 kilometer grid cell throughout the continent. So this is our map of cholera incidence, and there are places where there's high risk, or people sometimes like to say cholera hotspots within the continent. And you can see that this area in the lakes region of DR Congo, shows up very very distinctly, as well as certain regions of West Africa. And so when we're thinking about public health interventions, we're not just thinking about rates, but we also want to know how many people are at risk. So we can pair this with data for world pop and actually get the number of cases we expect each year in each 20 kilometer by 20 kilometer grid cell throughout Africa. And so that's what this map is showing us, with the darkest areas being around 10,000 cases a year, most of the continent having far, far fewer cases. So if we use these techniques, it gives us a way to see, okay, what are the populations that are actually at risk for cholera in Africa? And we've also, done this for the IMRO region, WHO IMRO region as well up here. And what it comes out to do is if the people at really high risk for cholera, where they have about over a 1 in 1,000 person annual risk for infection is about 17 million people. So, and that means they're living in a 20 kilometer by 20 kilometer grid cell where the risk is that high. So that's much, much slower than the population of Africa. The next sort of more moderate risk is 29 million, and then sort of the 5,000 to 10,000, one case per 5,000 to 10,000 is around 23 million. So if we wanted to vaccinate this highest risk group, we also took this to the next stage and said, okay, what would the operational needs be? Because you can't really go to a country and say, okay, vaccinate these 20 kilometer by 20 kilometer grid cells. That's just not the way public health policy happens. So if we vaccinated the districts, all the districts in Africa completely, so gave a vaccine to everybody, where there was a subpopulation with at least a cholera risk of 1 per 1,000, a significant subpopulation, that would take 64 million doses. Now that seems attainable from the 10 million doses we had last year. That seems within the realm of possibility and seems like it might be cost effective compared to going after the billions of people who are at risk if we take a country level view. So, okay, so we know where the cases are. That's one question we like to ask. A second question we might ask is, where are the cases going to be? And this is often comes out in forecasting as just something that is just assumed, okay, I would like to know where the cases are going to be, and to some extent that's true, but I like to frame it in more distinct questions. So, given that we're likely to experience a post-invasion lull in Zika virus cases, and I'll talk about this in a second, how do we test a vaccine? How do we prove a vaccine efficacious and be prepared for when the infection potentially comes back in a decade or two, and actually have tools to combat the disease then, like we didn't this time around? And to get an idea of why I'm saying there's a lull, this is some modeling work we did with Imperial College, and based on just invasion dynamics, when a virus enters a fully susceptible population, it's like a spark in the woods where there's dry brush everywhere. There's a ton of fuel. And you get a very, very, very intense fire or intense epidemic. And that's what we appear to be in the midst of now with Zika throughout the Americas, or actually at the tail end of. But after that fire or epidemic is so intense, it takes a long time for susceptibility to build up in the population, or the fuel to come back in the population through births, such that we can have another epidemic. So even if a disease will have sort of an endemic and eventually have an endemic cyclical existence, often after a big epidemic, or we actually see this after big vaccination campaigns too, you have a long time where it's appeared to go away. This is an estimate from, based on this very specific modeling estimate, we, think it would be 20 years, but I think more generally we can think of this to be in the 5 years to a couple decade range. But when it comes back, it's still likely to affect pregnant women, and we will still want to do something to control it. So, given that we're at the downside of this first epidemic, and we have this limited window to test the vaccine while cases are still occurring, Where should we do it? That's the question. And people have been taking, we're part of a group that's been taking a few approaches to this, and some building sophisticated models, but the approach we're taking is saying we don't need to build a sophisticated model of Zika because nature has provided one for us, and that's dengue. So dengue is carried by the same mosquito as Zika, except for serotype interactions, which I'll talk about later. It seems to have similar epidemiology and range. And it's been in the Americas for, depending on the strain you want to talk about, for a couple decades or more, or less. And so we can go and we can measure the transmission intensity of dengue and use that as our model of, at least in a relative sense, what we would expect for Zika. So using some models that estimate transmission intensity based on average age of infection, we, here I'm showing it for Brazil on top and Colombia on bottom. We went and we estimated the transmission intensity of dengue in various areas as the force of infection. So these maps on the right show the force of infection for dengue in Brazil and Colombia. And you can see that on the left, we have measures of Zika transmission. So on the top for Brazil, we basically just have microcephaly incidence, but that appears to correlate quite well with what we're seeing from the dengue transmission intensity. And then the bottom, we are looking at actual confirmed cases of Zika in Colombia, and that also correlates quite well. So we have this model, and then we can take that and, and that didn't come out very well, but I apologize. So this line just continues down, and it's all beautiful correlations, trust me. So this is for Mexico, and we have this for most of Mexico. We can take the statistical approach, and we have this very nice linear relationship between a transform of Zika incidence, of a measure of Zika incidence, and the force of infection for dengue on the x-axis. Except there are these two outliers here that are very clearly have far less dengue infection, or far less Zika infection than would be expected based on the force of infection for dengue in those areas. And those are here and here. This is Michoacán and St. Louis something or other. But they are, so those are, if we're going to go and try to conduct a trial in Mexico, these are potential targets to go conduct our trial. So another question that seems like it might be similar to where the case is going to be is, where are the people at risk for disease? And it's a subtly different question, right? Because where the cases are going to be presupposes the disease is going to get there. And there might be people at risk where there aren't cases. For instance, probably everybody in this room is at risk for Zika infection. Probably none of us are immune. But none of us are likely to get it, at least while we're here in Durham. So we looked at this, and so I'm going to talk about an example where we looked at this in relation to measles virus. And our questions here are, where are the populations with lowest coverage of measles vaccination? And how quickly does risk accumulate in these populations with disruption to coverage? So here we didn't have to go and suck up data from a bunch of different sources to do the mapping that we did. We were able to use demographic and health survey data. These are surveys that are conducted in countries throughout the world, in particular in Africa. These are countries in the lake region of Africa. And people are administered a battery of questions about their health status, one of which, or a couple of which, revolve around whether or not they've received measles vaccine. And in recent DHS surveys, these survey locations, the households are geolocated to these clusters that somewhat obscure their source. So we could take this data and fit statistical mapping models to get a map of measles vaccine coverage throughout these countries in the Lakes region of Africa, Great Lakes region of Africa. And sort of the green area here, that's the target everybody is looking to obtain, right? Everybody wants 90% plus coverage for measles vaccine. And as in these red areas, you could consider cold spots for vaccination, sort of the inverse of hot spots. And these are the areas where people are getting missed by the vaccine. And it's important to realize, once again, we don't just care about rates, we care about cases, right? So I'd like to, so we want to take this and merge it with population data and figure out exactly how many susceptible people there are. And I'd like to draw your attention to this central area in DR Congo and this area at the northwest of Lake Victoria up here. So we've paired this with population data, and here the red areas indicate the number of unvaccinated people living in an area. This is by 1 kilometer by 1 kilometer grid cells here. And you can see that, okay, even though vaccination rates are low in central DRC, it's all jungle, right? Nobody's living there. We're not actually having a huge problem of a lot of people being at risk for measles there. Whereas the vaccination rates are marginally higher in Uganda near Lake Victoria. They're still a bit low, and it's one of the most densely populated places on Earth. So in terms of actual number of unvaccinated children living with any given square kilometer, it's actually quite high in this area. And that's where the unvaccinated children are living. So this is showing sort of what we expect on when things are going well, or not well necessarily, but things are going stably. And one question we might ask is, okay, what happens when things aren't going well? What happens when there's disruptions? Because we know that because measles is so infectious, when there's disruptions to vaccination programs and disruptions to healthcare systems, it's one of the first diseases that we see come in after those disruptions and start causing cases. And we looked at this in relation to Ebola again. So if you were paying attention to the news at the time, you might have saw a lot of stories about what the healthcare infrastructure looked like in countries of West Africa prior to Ebola and what Ebola was doing to those countries. So, for instance, this is from the BBC giving a sense of what the starting point is, that Liberia has 51 doctors to serve a country of 4.2 million. These are local people. So that's an average of 0.1 doctor per 10,000 people. Whereas Sierra Leone has 136 doctors to serve 6 million people, so 0.2 doctors per 10,000 people. So the situation is not great in terms of healthcare provision to start with. But when Ebola struck, two things happened. One is that people knew that healthcare centers were a place where you might be more likely to encounter Ebola patients. Sometimes it was transmitted in healthcare center clinics, so people started avoiding healthcare clinics. So, and then the other is a lot of healthcare clinics closed or resources were reallocated to deal with the Ebola crisis rather than responding to routine healthcare needs. So, for instance, MSF did a survey, that's Médecins Sans Frontières, did a survey of healthcare clinics on Monrovia at the time and found only about 60% of them were open, and those that were open just weren't getting patients. And you saw headlines like this: with Ebola crippling the health system, Liberians die of routine medical problems. And in this story, they talk about a pregnant woman who dies in their car in front of a hospital because she can't get in for appropriate care. Or when Ebola kills, but now routine health problems do too. So we wanted to say, okay, if these disruptions are occurring, how quickly is a problem with measles under vaccination accumulating, and how big is that problem? So this animation here shows what we get by taking mapping techniques like of baseline immunity like I showed before and vaccination rates like I showed before, and pairing them with the demographic models and looking at how quickly susceptibility is accumulating over time under the perception of a 75% reduction in measles vaccination rates, which as at the time we were doing this was our best estimate of what those reductions would be. And you can see that over the course of 18 months, significant numbers of susceptible people are accumulating throughout the country, and we're seeing significant increases. And at the end of that time, the result is that we have an inflated large body of susceptible individuals that's interconnected throughout the country, that's at high risk for measles and is abutting smaller but still significant areas in the neighboring countries in West Africa. So there's a significant potential problem of measles outbreak. Now, if you want to get the attention of policymakers and get something done about this, you can't just say, oh, there's a lot of people out there susceptible to measles. You got to say how many people are going to get infected and how many people are going to die. So in order to do that, so how do we do that? And one way would be to take this sort of massive agent-based modeling approach that I discussed before, but we neither had the time nor the data to necessarily do that in an effective manner. Another is to take a purely statistical approach. From work that one of my colleagues, Matt Ferrari, had been doing, measuring measles burden worldwide for a long time, he'd come up with a model that captures the relationship between the proportion of population susceptible and the average yearly attack rate for measles in the susceptible population over time. So we have a statistical relationship that allows us to predict how bad, or model how bad a measles epidemic will be without running a model, using sort of all the past measles epidemics as our model. And using this, we projected forward exactly how much worse a large-scale regional outbreak of measles would be if this held. And so one thing to note is that part of the problem was the risk was already high coming in. All 3 countries had measles vaccination campaigns scheduled because their vaccination had gotten too low and they were anticipating potential measles problems. And all these campaigns were delayed because of the Ebola epidemic. So at the start of the Ebola epidemic, we estimate that there were around 890,000 people susceptible across the 3 countries, and that a generalized epidemic would infect in the neighborhood of 126,000 people and kill around 65,000. After 18 months of disruptions at the level we were anticipating due to Ebola, we would expect there were 1.2 million people at risk, and then a generalized epidemic would infect 227,000 people and kill around 12,000. So almost doubling the severity of the epidemic, because it increases non-linearly with increases susceptibility. Fortunately, I'd like to think at least partially based on this work, they did do vaccination campaigns in June of 2015. Some of them started, and they sort of moved up the timeline of vaccination campaigns. And we didn't see any large regional outbreaks like this, but we did see in some places in Western Guinea, for instance, that there were localized outbreaks that had attack rates similar to what we're sort of projecting here. So I've talked a little bit here about this heterogeneity in risk and how it builds up. But you might ask, okay, how much does this matter? And does it matter in ways other than this sort of linear increase in susceptibility that I've been talking about? So, so the question here is, how does the heterogeneity in risk impact control? Or more specifically, how much harder would a country have to work to eliminate measles because unvaccinated individuals cluster together than if these individuals were spread evenly throughout the population? So to think about this, let's think about this this infectious guy here in a population where around 80% of the population has been vaccinated. So vaccinated people are in blue, and unvaccinated people are in green. And we tend to have contact with people who are closer to us on either physical or social distance than those who are further. So if he infects people, we'd expect, based on this data, if he has potentially infectious contacts with 5 people, we'd expect, based on an 80% vaccination rate, 1 person to be infected. Now imagine if all those unvaccinated people clustered together. So he's here, and all the unvaccinated people cluster together near him. And he has those same 5 infectious contacts, once again tending to be near him. Here we have, say, 3 people be infected. And so it would be, so there's a far more infections occurring because unvaccinated people aren't distributed randomly throughout the population. They're clustering together. And this brings us back to our equation that I sort of started with, this 1 minus 1 over R naught equation. This is assuming those unvaccinated people are evenly distributed throughout the population. So how can we adjust this to get a sense of how much heterogeneity or clustering in unvaccination is hurting us as we go forward to eliminate measles? Well, the first thing we need to do, I need to tell you here, and we're going to have a brief spate of equations here, and then we'll leave them again. So just to warn people. Is that the reproductive number, so the number of people you expect someone to infect in a partially immune population, is equal to, if all immunity comes from vaccination, 1 minus the rate of successful vaccination times the basic reproductive number. And that equation of 1 minus 1 over R naught comes from the fact that if this reproductive number is less than 1, every infectious person in the population isn't expected to replace themselves. They're not expected to infect at least 1 additional person. Therefore, the epidemic must die out because the infected people are not able to replace themselves in the population. So, if we break this down a little more, that basic reproductive number actually comes from a process. And that process is that somebody has a particular number of contacts during their infectious period. And those contacts, each of those contacts has some per contact probability of transmitting the disease. So I've captured that here by C times beta. So we can actually think of really what the equation is saying. It's okay, we have our contacts, we have our probability of transmission, and we're then multiplying that times the probability that that contact is unvaccinated. So once we have that idea, it becomes clear how we might adjust this to take into account the clustering. So we can take this, if we can get a measure of how much contacts cluster together, or unvaccinated people cluster together. So the relative probability that if I'm unvaccinated, the contact at a particular distance is also unvaccinated, versus anyone else in the population. So this is captured by this tau function here. And the distribution of distance at which contacts occur, captured by this g of x here, we can come up with an estimate of the reproductive number that's adjusted for that process. This can be simplified slightly by replacing that C times B, which is hard to measure, particularly the per contact transmission probability, with R naught, because that is actually measurable. So we have this equation that gives us an adjustment, and we can see how particular levels of clustering might affect our ability to eliminate disease. So for an example that comes from a simulation, on the right here, or the left here, you have a population where unvaccinated people, shown in green, are evenly distributed throughout the population. So this is a population where 95% of the population is vaccinated. We're going to pretend disease is a measles-like disease. So the basic reproductive number is 18, and here the unvaccinated people are evenly distributed for the population. So this tau looks like this. It's a flat line. So in that situation, the 95% vaccination rate reduces R to 0.9. So it's under 1. So if a disease entered this population, it would not ultimately cause a large epidemic. Whereas if these under-vaccinated people were clustered together, and we vaccinated the same proportion of the population, but the clustering looked like this, we get an R of 1.6, which is well above 1. So in this population, an infectious person entering the population, presuming that they're more likely to have been unvaccinated themselves, is far, far more likely to cause an epidemic. And this might explain, and we're doing some work to figure out if it does right now, this might explain some things we see out there in the real world that are sometimes puzzling. For instance, if you look at overall vaccination coverage rates in Tanzania and Zambia, Tanzania apparently has a much better vaccination program than Zambia. Yet Zambia managed to eliminate measles for 6 or 7 years. It did come back, whereas Tanzania didn't. But if you look at the clustering in vaccination, Zambia has far, far less clustering in their people who aren't getting vaccinated compared to Tanzania. So I'm going to end with a little talk about everything I've talked about so far has been sort of scientific, policy in nature, very public health policy, on the ground oriented. So I'm going to end talking a little bit about the science of this. So, because as scientists, we're not just interested in what the policy implications are, but we think it's useful to know what are the processes by which these heterogeneities of incidence occur. So, for instance, what is the structure of actual chains of transmission that are leading to the distribution of disease that we see in the general population? And how do these differences impact our understanding of illness? Right, so we know that any infection we see from an infectious disease, by definition, comes from some transmission chain from some people who are observed and some people who aren't. And those transmissions in terms of their spatial distribution, who gets infected and who doesn't, have some distribution that ultimately leads to a pattern of disease. So this is a point pattern of dengue in Bangkok. So it leads to patterns of disease that sometimes we observe specifically. We actually observe that individual place, that person was infected right there. And sometimes we observe sort of at this geopolitical boundary level. So we have that, and what we want to know from that is, okay, what are the chains of transmission? Can we figure out something about the chains of transmission that are actually causing these patterns? And one tool we have for doing that is molecular data and phylogeographic analysis. So we did a study where we sequenced over 800 dengue viruses from Bangkok and elsewhere in Thailand, and looked at the phylogenetic trees. And all these viruses came from people who were geolocated. We knew where they lived. And just as a reminder, dengue is, in Thailand at least, is mostly a childhood infection, so these are children. And then we also have various data from other places throughout the country, from other surveillance systems. And we took these and we built phylogenetic trees, and we looked at how the geographic relationship between individuals corresponded to the evolutionary relationship in real calendar time. So here we're going to define a chain of transmission as two people who share a common ancestor. So somebody who infected, chains of transmission who infected both of them within the past 6 months. So just for the purposes of this, we call that a chain of transmission. And that roughly is saying, okay, they were infected by the same lineage during the dengue season. And if we do make that definition, if you look very close, so for the moment, look at this axis up here, it's distance, in kilometers. If you look very close, so like within 200 meters of a case, there are approximately 1.7 chains of transmission within that area. So most people in that area, most other cases in that area are related, and if they're not related to you, they're likely related to another case in that area. So the local epidemics are actually driven by very few chains of transmission. And then as we go in a bigger and bigger and bigger area, we see more and more and more chains of transmission. Ultimately, by the time that you're around 5 kilometers away, you're seeing like over 200 chains of transmission, and that's about the same amount you see in all of Bangkok altogether and all of Thailand altogether. So we can measure how quickly the number of chains of transmission are increasing, which is telling us how related dengue cases are in particular spatial scales. So you might ask, well, is this a geographic phenomenon or is it a population phenomenon? Right? Because essentially, if we take the average population with density within Bangkok, we can essentially rescale distance to population, and we're seeing a particular increase in the number of people enclosed in each of these spatial areas. So we wanted to say, okay, is this a geographic or population-based idea? And so we took various radiuses and used the heterogeneity in population and density within the city to see how, within a given radius, how the number of cases or the number of chains of transmission increased as we increased the population within a fixed area. And the general trend is as you'd expect. As you increase the population in the area, you see more chains of transmission, up into a point. At some point, at a density of around 7,000 people per kilometer, it saturates, and you actually start seeing less chains of transmission as you get denser and denser population. And you can show using mathematical models that this is actually the phenomena you'd expect if you were seeing dengue cases, related dengue cases separated by about 50 meters, and competition for host, right? If I'm infected with dengue already, I'm not available to be infected again. So how do these processes relate to the actual cases we see in real life? So I'm going to walk you through this, and to understand this, I'm going to have to at the same time walk you through a little bit about dengue epidemiology and pathogenesis. So dengue has 4 serotypes, and we're gonna call here, this is all cases, we're gonna call homotypic, meaning somebody is infected with the same serotype as some index case, and heterotypic, meaning that somebody is infected with some different serotype as an index case. So as you'd expect, so in this figure, this is a time separation and this is geographic separation. As you'd expect at short temporal separations, you see a lot of homotypic cases near an index case. No surprise there, it's an infectious disease. If I'm infected with disease, people around me are more likely to be infected with it because I might have made them sick. But the pathogenesis of dengue in epidemiology is complicated. If I'm infected with one serotype, I'm immune to that serotype for life. So I'm protected from that serotype for life. And you can see that signature in this data because near a case in the coming years, you see lower incidence of that serotype because we know that the people around there were more likely protected against that serotype. But my first infection only protects me against one serotype. And I temporarily am protected against all, but after a little while, I'm actually at higher risk from giving severe disease if I'm infected with a second serotype. And therefore more likely to go to the hospital and be detected by a surveillance system. After that second infection, I'm generally thought to be immune for life. And if you look at this heterotypic infections, you can see the signature of both of those processes. Over moderate time scales, we see a reduction in all serotypes because there's this short-term cross-immunity. captured by this blue here. But over longer timescales, we actually start seeing higher incidence of other serotypes in that area around the case of a particular serotype than we do in the general population. So this structure of we're seeing of localized transmission, shared trains in a local area, is having a visible impact on the distribution of disease we see in the general population. So just one final thing to wrap up. I know everybody is burning to know, is it Groundhog Day? So to remind you, if it's Groundhog Day, we have gangbuster epidemics that go very fast, but ultimately infect less people. If it's anti-Groundhog Day, if it's random day, we have slower epidemics that infect less people. So we actually have a study in southern China where we've been administering contact surveys to the same people year after year for a while. And at the point that this analysis was done, we've done 3 rounds. So we have 3 rounds of contacts. And we can plug this data for number of contacts into a multi-level model and get a sense of the proportion of contact variation that is due to differences between individuals, so differences between me and you, and the proportion of variation that is due to differences on just because talk to you on one day or another random day, roughly a year apart. And if we do that, sorry, I stepped ahead, but if we do the overall trend, and you'd be forgiven to have missed this the first time I showed these, that each of these has 3 lines. So the overall population level of distribution of number of contacts, distance they are from home, number of destinations is incredibly stable over time. You don't need a statistical test to know that all of these are roughly the same distribution. But when we look at the individual level, like I said, we see that it's not, that the variation in the individuals is more. And overall, roughly 45% of the variation in log number of contacts can be attributed to differences between people. So it's 45% Groundhog Day. 45% of how much variation you're seeing in contacts is because you're you, and overall, the rest is because differences from day to day, separated by a year mark. And as you might expect, the number of contacts we have at places like home, work, and school are really dependent upon who we are, right? We tend to go to the same places there. But when you look at things like eating or drinking, running into people on the bus, friendly visits, far more of the variation is just due to random differences day to day. Likewise, there's patterns by age. So 10-year-olds, well, these surveys were done a year apart, right? So people under 10, if you interview a 5-year-old and you interview a 6-year-old, they're about as different as 2 5-year-olds, right? But as you get older, you get more regular over time. And when you're around my age, you just do the same thing. But evidently, I'm going to get more exciting in the coming years, but only marginally so. So anyway, I'm going to leave it there. I'd like to thank numerous funders, particularly NIH, Gates Foundation. And here's not all of this is published, but some of it is, and here are some papers where you can see some of these results if you're interested. And I'll take any questions.
So Justin, thank you for a very interesting talk. We have time for a few questions.
Yes.
How do you predict the introduction of new serotypes or mutated strains?
So, it depends. So, in Thailand, for dengue, all serotypes are circulating all the time. So you can be different serotypes dominate in different years, and you can somehow get it the way that those interact to what serotype's likely to dominate, because by looking at the serotypes that have come in recent years, so if we had a big dengue 3 year and a big dengue 2 year recently, it's far more likely we'll have a big dengue 1 or dengue 4 epidemic. But that's, in context where all 4 serotypes are circulating all the time, and they are, likely, they're always invading. Or people are always getting exposed. So sort of that immunodynamics dominates. But if you're talking about true novel strains and true novel introductions, it's a stochastic process that, frankly, there may be no good prediction, or it's a good prediction that's, a good prediction is, it's this black swan event, right? The probability of a new strain of Ebola rising, or a new highly pathogenic pandemic flu rising in any given year, far, far less than 1%. And we can maybe calculate that. The impact, if such a thing happens, is huge. So, and we're, in any context, we're notoriously bad at dealing with low probability, high impact events. Yes?
You mentioned at the end of your talk how phylogenetic information was incorporated from more basic science level understanding, but what is the state of incorporating phylodynamic inferences into actual public health, for actual public health implementation?
Right, so, it's often used like when we actually come down to actually tracing outbreaks and doing contact tracing. And there's several cases where we've had very complete observations of outbreaks, particularly, for instance, one instance of a TB outbreak in Canada, where using the phylogenetic information has allowed us to really see the structure of transmission and understand the outbreak as actually there. It allowed us to realize there were actually two separate parallel outbreaks going on. It wasn't a single outbreak. But, and I'd also say that the basic scientific understanding isn't divorced from the public health understanding. So, for instance, there's been some phylogenetic research in the Netherlands that shows that the cases are not being, new cases of HIV have not necessarily been driven by new introductions coming into the country, but it's really long-standing, long-running chains of transmission that are driving most of the new disease, which has public health implications there. Or in here, where we understand the spatial scale of dengue transmission, it has sort of a once removed implementation if we're going to do case-driven response. So if we're going to go do vector control around the case, do we do that at 50-meter radius? Do we do that at 100-meter radius? Do we do it at a 10-kilometer radius? Understanding the structure, that microscale to structure of disease transmission, can help us to do that in an effective manner.
So we have just enough time for one short question and short answer.
Short question. So you're doing a lot of scenario-based, projections of disease, and I'm wondering how you're engaging policymakers at different levels. So if you have these inter-country estimates of dengue or measles or cholera, are you going to the health systems and showing them these scenarios and trying to help them think through policy strategies?
Yes, every time. All of this except the last section was policy-based work. But it varies every time. So our work on cholera is predominantly with the Global Alliance for Vaccine Initiative, the WHO, and MSF. So these big international organizations trying to set global vaccine policy. Our work on the, for instance, on Zika is actually, that was prompted by a request from the CDC and the NIH, and that is we're part of a 3-institute modeling consortium that's deciding where those vaccine sites are actually going to be. Others are, Thailand we're providing, wasn't quite the work I talked about here, but we are getting dengue case reports for them at a bi-weekly level and feeding back real-time forecasts of what the dengue epidemic is going to look like from them, real-time, every 2 weeks, then. So every one of these is part of a policy and practice engagement, with the exception of the scientific ones I noted at the end.
Justin, thank you for a very engaging talk. Please join me in thanking him.